just a few examples. I'm not going to show you initially any numbers. So these are, you can just look at the waveform, the size and the shape. This is somebody in atrial fibrillation, a little bit of electricity, and this is literally, 10, 15 seconds later. You can see, sinus rhythm, that atrial kick. Nice big, fat, juicy waveforms compared to the irregularly not so good waveforms. The joys of electricity. Price's paradox. So again, you see a big respiratory tree. You can see it obviously on the outline too, and again you see the stroke volume swinging with like the severe asthma and high airway pressures or pericardial effusions or whatever. Here's an example of somebody on the ICU, and you can see obviously the average to the corrected flow time. You can go beat by beat, or you can average. Usually if it's sinus, I average over 5 beats, and if it's like AF, you could do it over 10, and a big machine goes up to 20, it can average over. But you can see, there's obviously a big swing, and to be fair, the art line says a swing, not great blood pressure either. There's something wrong with the patient. I think you all agree. And you can see very, the tachycardic, 156 heart rate, I suppose. And you can see a nice rim of fluid around in the pericardium, obstructing the flow. So again, it looks very constricted, in inverted commas, hypovolemic. It's hypovolemic to the left ventricle. It's just that the fluid just can't get into it, so it's pumping hard, but it hasn't got much volume to pump. And obviously, relieving the pericardial fluid made a difference. Atrial placing. So again, patients with a poor heart, often the atrial kick can make a big difference. And this is before or after switching on atrial pacing. And we can see it sort of double the twilight output. Remember I was talking about a little bit of reverse flow is normal? So that's okay, but you can see, again, you're not going to give you any numbers, just see it's doubled. Just, doing that atrial kick 15 seconds apart. This is a patient in the early days when I was going into cardiac theatre and we were just sort of observing, we weren't interacting with the pro. But you can see this is a patient before they went on bypass. And, the blood pressure was holding, but you can see things were looking worse. And at this point, the pressure did crash and the patient has to go on to emergency bypass. But you can see, just look at the deterioration much sooner. And so, again, we're going up that learning curve and getting the confidence we could intervene before you get to that collapse stage. I mentioned aortic regurg. You can see forward flow, reverse flow, so the whole length of diastole. And this is a patient who we knew had aortic regurg because he was having an aortic valve replacement. For aortic regurg to the aortic regurg. At the end of the operation, this is better, but it's still there. And this is in the days before TOEs were being done in cardiac anesthesia. I thought, this is the way it should be. Still get this, and without telling the surgeon, I arranged an unofficial echo, which confirmed he had a paraprosthetic leak. And then, it was still alive. I told the surgeon, actually. And he said, but it's better than it was, so I'm happy. Well, I think fine. And so every time after he was changing about, he said, does it look all right? Yeah, fine, amazing. So he did take it on board, and I'm still alive. Okay, let's see that before and after. Okay, this is a lady who came in with septic shock. And as you can see, not the healthiest. The lower limb and the rest of the body was equally 1/7. Again, the Doppler showed a whacking forward flow, but obviously you can see here there was a big reverse flow. So this is what's going out, but some of it's actually going back in. But it's still a high output state, isn't it? Peak velocity was sort of literally off the scale. Normally for her age, it should be about 50 to 80. And this is 208. Oh, sorry. Yeah, 208. Not so good. Diagnosis? The aortic regurg. So she had bacterial endocarditis, and which hadn't actually been picked up. She came in with septic shock, came to the unit. Did that? Got an echo, confirmed she had endocarditis.
I was rude about metaraminol. I'm still rude about it.
It's you know, the anaesthetist go-to drug when the blood pressure's low, boom, blood pressure's all right, we're happy. But again, if the heart is poor and it doesn't like it, again, this is before and after. So yes, have I done well? The blood pressure's come up. At what cost in terms of perfusion? To be careful. So yeah, in a nice healthy heart, especially if you don't, the blood pressure doesn't shoot up. Yeah, metaraminol is okay, but especially if they've got a poor heart, the heart doesn't like that rapid increase in afterload. And this is actually a very consistent finding in patients who have poor hearts and get metaraminol. And again, whinging about the sort of shift in pharmacology, but it seems as we sort of go-to drug in the emergency department. Patient's got a low blood pressure, give them some metaraminol. Oh, please.
So, so crucial metaraminol infusions of biphosphonate.
Yes.
And low-dose NORAD might be, but they're trying that primarily from a low-dose, she's out of 1 into a litre, and you're very low-dose. Maybe that's,
well,
it's quite confident that the elderly can move on metaraminol.
Yeah, no, absolutely. And if you don't know what you're doing, you don't see necessarily the consequences to it. 100% agree. And it is, and nobody's done head-to-head of metaraminol versus NORAD, and actually they're structurally related. So they're actually quite similar.
It hasn't got much in the central line of NORAD.
No, Noradren's got a little bit more, but it's still nowhere near like adrenaline. But no, you're right. And so it's got popular because, you can give it peripherally. Although now, I don't know if you've seen, there's new NICE guidelines on sepsis, where, again, the evidence shows you can, provided you've got a good cannula in a good bay, you can use a peripheral NORAD.
Not at it.
Felt very tight. I mean, well, not tiny. You can actually go higher doses. There was always the fear of, you can't give NORAD peripherally. But in fact, the studies that go out, they show that even relatively high doses, high concentrations, provided you've got a good cannula, it's in a good way.
You can obstetrics now, it's private peripheral NORAD, and when you get this final in drops, practice peripheral NORAD, American studies are done.
Again,
suspect you're protected for the baby's outcome as well.
Oh, really?
Yeah, in terms of cardiac output, no percent of perfusion.
Is that as a comparison against? Because they don't use metaraminol, phenylephrine, which is much purer of an alpha and doesn't have much. Yeah. And I told him we gave each other drugs. Phenylephrine was one of the drugs we gave. Yeah, man. Not a nice drug. Yeah.
We've also started using peripheral NORAD just until it's kind of early days, but we do it in 250. No, we do. Yeah, 4 milligrams and 250.
Yeah.
No, yeah.
And you could probably, again, you can probably go more concentrated, but, it seemed, which is a good argument that, do I need to wait until I get a central line in before I actually start giving them a vasopressor, if they need a vasopressor? So, again, if it was me, what would I want? I want, get my blood pressure up, please.
Yeah. You don't actually do a study because in take a female patient now, it's quite popular. So we have team assess with a triple lumen. I'll have a third lumen for peripheral perfusions. But it'd be quite interesting actually to put a Doppler on in these patients to see if we more metaraminol, because the team obviously was purely anesthetic and have to counteract the effect. Maybe I could do that as cure.
That would be fascinating because again, please correct me if I'm wrong. I've not seen any head-to-heads of metaraminol against NORAD.
Yeah, so they're diluting for the obstetric. They're diluting that 4 milligram ampule of NORAD into, I think it's a litre, so it becomes really dilute. So where it does, like 16 micrograms in it.
And they're not too worried about the volumes. They can infuse fairly high volumes.
Yes, it's just purely for the until baby's delivered. So it's not for very long.
Yeah. And that's just more in response to the epidural.
Yeah, it's spinal injury. Yeah.
Oh, it's spinal. Yeah, sorry.
Yeah. But I'm just saying, because we use a lot of metaraminol infusions now. Yeah, and very elderly.
And it does scare me that, if you suddenly know what you're doing, then you might think, maybe this. What the eye doesn't see, the heart doesn't grieve over.
You can make the better message.
Obviously, it's the higher the pressure, you're putting more resistance, hence which the heart has to pump. But you sometimes see, obviously, yes, if the blood pressure is really low, you've got to do something. Burns.
dare I say, again, the way I've seen methamphetamine used, it tends to be in a bolus, and then things shoot up, but it's quite hard to judge the bolus. And it offers like an induction, where, obviously some patients have, maybe they're hypovolemic or excessively responding to the propofol or whatever, and things crash. You meditate. But it isn't obviously better as a mean of 60 than a mean of 18. But it's like everything. So with infusions, probably better because you can titrate rather than exactly. And you're waiting for a few minutes if you come down. Yeah, indeed.
If we do to have patients, like,
Okay, this is a study. This is just, again, a quick example of a patient who was admitted to a synthetic shock from the ward, 62-year-old. He was hypotensive, not particularly tachycardic, but he was already on NORAD 0.4, so decent dose. He'd been given some fluid on the ward. CVP was 12 and the lactate was 7.4. Not well funny. Oh, sorry, let me go back. So again, what do you think, looking at that waveform, what do you think? Oh, I have slurped my copy. What do you think, looking at that waveform and the numbers? Very narrow, corrected flow time. Yeah, exactly. It's 160. Yes, it should be 330 to 360, 350.
Is that straight volume or PV at the top? Is that pulse 3 straight?
Stroke volume 43, PB 103. So you're obviously getting a little bit of the inotropic effect when you set it, when getting NORAD's giving a little bit. So the heart's pumping well in terms of contractility, but really, really, really narrow. So does he need fluid?
Yes.
Probably, exactly. Does he need so much NORAD? No, perhaps not. So this is an hour later. You can see there's the times up there. So this is 10:48. 3 litres of fluid. And now the blood pressure is a bit better. Yes. The heart rate's the same. CVP, despite 2 litres, because you're opening things up. With 10, the lactate's improving, and he's now down 0.4 to 0.12. Does he need more fluid? The corrected flow time 287. Yes. Yeah. So again, but rather than just flood the fluid in, we challenge, look at the response, challenge for the response. And now at 55 hours, he needed just 1 more litre. He was now off the NORAD. The blood pressure was okay. CVP was still the same. The lactate was just about normal, and that was up to the normal range. 80. No, but it was, that doesn't look good, does it? That looks a lot healthier. Okay, now let make you do some work. This is a 43-year-old woman who had a long history of asthma, and she came into hospital with a sort of 3 months of increasing lassitude, tiredness, increasing breathlessness on exercise, and got worse in the week prior. She had a temperature, cough, ease. She was given all the sort of standard anti-asthma stuff on the wards, and then they added in stuff, and she wasn't getting better, so she came to the ICU. She was wheezy and tiring. Her chest actually was just clear, and on examination there were sort of wheezes and crackles of upheavals. Okay, and she became increasingly tired within 3 hours. She had some BiPAP, failed, she needed tubing. She was ventilating okay, but, a bit odd for an asthmatic. It was very easy to ventilate her. You'd expect she should be having higher aggressions and long expiratory time. It wasn't the case. Yet she was leaning a very high amount of oxygen. There was some, on a repeat X-ray, a bit more shadowing. I think she had some pulmonary edema, or was it ARDS? She was tachycardic. There was a bit of right axis deviation on her ECG, but that was it. And they were her numbers. So she had a good blood pressure. She was tachycardic, and the CDP was 14. Okay, what would you do now if you didn't have any flow monitoring? Again, no shaming, saying anything, because that's it's just the challenge of what you do in this situation. Yeah. Any offers?
Well, this is a focus, think point up.
Okay.
Get up, just
How good is POCUS? Yeah, that's the problem. So I think POCUS in the right hand is brilliant. Unfortunately, the number of times people get it wrong. So if it's done well by somebody experienced, then it's an absolutely great technique. I think, unfortunately, often number of times you've had, I'm not good at it, so I don't claim expertise. So the number of times you go, oh, this is what's going on, and then actually something else is going on. So it very much, I think it's a lovely diagnostic. And as a monitor, so and if the walls are collapsing, then it's likely the patient probably be fine. But again, in assessing a 200 ml fluid challenge, has it made things better or worse? I defy anyone who does POCUS, unless you're doing the Doppler component and looking at sort of stroke distance to actually say, it's a meta. So wonderful diagnostic in my hands, absolutely. Not so great for monitor.
Is there anything on blood gas amounts?
Acidotic.
Is she on neuromuscular drug pain?
No, not at the time, no. Well, she'd had soon after intubation, that wore off, but no. CTPA, okay, but we'll come back to that in a moment. Yeah. What are you thinking on?
Self-awareness.
Yep. Again, good possibility on the list of differentials, absolutely. Any other thoughts? How would you manage the hemodynamics? Are you not faster? A little bit, the lactate's a little bit high. Heart rate high versus blood pressure's good.
She is on the solid.
Yes, that is what's could have confidence after. Yeah, could have good exactly. It could be. Then I'm not find this check. And the CBP is 14.
Yeah. You could try cautious.
Play champion.
If you could try cautious fluid after and see the embed. Yeah. All of these things. And this is years ago, and this was actually with the nurses. I didn't have a camera on my mobile phone at the time. Now everyone had been evicted. The nurse actually very kindly took some photos and a little video for me. Okay, that was the Doppler. I'll show you the other numbers in a second. Again, you get resting flow time of 230. It's troponin absolutely very low, 33. The people off is 73, which isn't great. For a youngish woman.
And we see the swing as well.
And yes, it is a bit. It's not huge, but they're out of the swing. Yeah, there's a bit of sweetness. And as I said, she didn't have high airway pressure, so yeah. Okay. So what now with that? What would you think? Then try some fluid challenge. Okay. So they were when we put the probe in over the initial measures, and that was after fluid. So it was 21 mils. And then this is post-fluid, so it was 210, and we got it up to 230. So it still looked empty, didn't it? But the blood pressure and the CVP, this is after the CVP was even higher. And try the leg raise, straight leg raises at fluid challenge. I like having nitrate boluses, because I put it the nitrate test. So you get this short-lasting sort of dilation. And if they're well filled, cardiac output goes up. If you adjust the circulation to allow a sort of flow of blood through the circulation, but if it crashes, it suggests that the heart's empty for whatever reason. And I agree. Is she obstructed? She was acting as if she was obstructed, thinking about a PE. She was getting more and more unstable. So we thought, could this be a PE? And got an urgent echo. At the time, we didn't have our own echo, but. So the cardiology reg, actually, and it'd be rag kicking and squeak because it's out of hours to come in to do an echo. And again with the nurse's phone. Myxoma. Blocking, so you can see it here. You can see this plopping in and out of the mitral valve. Nice little myxoma. And she had pulmonary hypertension. Treatment? Management, surgery, and at the time, we had cardiac surgery on site, and so she was stabilised overnight, and then went to Piers at first thing in the morning, which was Friday the 13th, as it happens, and that is actually hers. So the anaesthetist who did the case to the picture, it was 65555. What chunky? And no wonder it was blocking the mitral valve. Pardon?
There's no space left.
No space there, exactly. And initially she was a bit rocky for a few days, but then actually made a full recovery. She said, "Oh, I feel better now, kind of you." Despite having, her chest cracked over, etc. The good done good. Okay, next one. This is Bricky, who, when I told the story, he was from Manchester, and his mission in life was obviously come down south to earn some money. He wasn't Andy Fernand. But obviously, and I think also as Le Fire later to inseminate as many young London ladies as he could. And he basically had a history of 5 days of feeling increasingly unwell. He went to his GP a day beforehand, really high temperature. GP said, "We've got the flu, go to bed." And the following day he was found moribund. So
The hospital. And when you arrive in the emergency department, he had a low GCS, tachycardic 155, blood pressure 130 over 50. He had a sort of purpura fulminans type rash, and his limbs were like marble. They were white, pulseless. He could feel at the femorals, but he couldn't feel anything below, and same in the arms. I think this is a picture of him. This is after he got resuscitated, so he was a bit pinker there. Diagnosis?
Yeah.
So, likely to be meningococcal tears. Okay, so treating antibiotic, yada. About the hemodynamics, how you can manage him, I'll just remind you, let me show you later. So these are the standard things, oxygen, glucose is all right, lactate was high, antibiotics, fluid, they reckoned he'd need an IC bed. Not unreasonable, caused price urge. Okay, so, classically, this is actually good, isn't it? 30 or 60 minutes, but it was making a bed for him. But in the meantime, he's in the emergency department. What are you going to do for monitoring this guy? How much fluid? Do you think he needs fluid?
Yes.
Yeah. And if the blood pressure falls, what are you going to do then? Or if it doesn't recover with fluid? Okay, monitoring. Like, obviously, you go say, "Doctor, pardon, art line, yeah, but he blood citizen, it's not going to be the February. Yeah, okay, yeah.
And I central venous.
Yeah, central line. Yes.
CJ.
Okay. Fluid, how much? So he's young, big, muscular, brigler.
I've got some Charles Willen and 500 lower coon. The big chop was to see what happened.
Yeah. How much? How much do you think he'll leave in the first hour?
Oh,
League lights, explain, or 3 to 4 litres, higher, lower?
Clinton, not commenting. So,
Give me a number. Come on, put your cards on the table.
maybe a couple of litres.
Any other thoughts, comments? I trade to CDP. Titrate to CDP, what challenge? Look at the response. Yeah, could do that. Good old fashioned carry order. Not disagreeing, a dynamic challenge. Absolutely. So you're agreeing he needs lots of fluid? Okay. I checked before I get that. I said, because they rang and I got component, I said, have given him anything. I get down. They were already giving him fluid, and I said, wait till I get down. Why? Again, grey hair. Horrible experience is these patients with meningococcal sepsis seems fluid like common. You often hear a patient coming to the emergency department, young for healthy people, get a lot of fluid, and then they die in the emergency department with pulmonary edema coming up the tube. Anyone seen that? Or heard of it? You do. Thankfully with vaccination it's now much less common, but you've seen cases like that. You're nodding. Yeah, heard of it, yeah. So you do, and the reason is they had profound myocardial depression. A young bit, not it. And so I took a Doppler down, and that was, so I don't have a picture for, unfortunately, but those were the numbers. And tachycardic, now he'd been tubed, his blood pressure was now 105. The CEQ was 12. On your own, and my own nerve goes up. Stroke from 22 in Leeds Madness. So it should be, in a young, fit, strong man, 100 plus. And the cardiac output friendly.
Okay, kind of fluid challenge. Result.
Yeah.
Yeah. Got worse. So blood pressure was dropping, serum volume was dropping, cardiac output was dropping. More fluid? No. Hang on, this is 200 mils.
The monitoring help. Okay, so what would you do now? Fluid, we've all already fluids probably isn't a good idea.
No adrenaline. Although NORAD just more of a vasoconstrictor than an inotrope, and he's got a pretty crappy battery health.
You put them in 2 napkins.
And I have EG, adrenaline, yeah.
That's what I did. So, in fact, and I thought Elizabeth GT had just said, because he was shut down just to try and open up the space, and he might need fluid later, but he needs to sort of get the heart adequately filled, pumping, and try and improve that circulation. And so, literally, within minutes, again, this is anecdote, it's not in textbooks, but these patients get a great big whack of dexamethasone, and you sometimes see literally at the end of the table or at the end of the bed, a blood pressure response, and I've seen that in a number of patients. I remember one guy, an American tourist who was septic, and literally he was getting huge dose of NORAD, and we were giving boluses, mimicking a big dose of Dex, and literally within minutes, not only were we not needing to give the boluses, we were actually reducing the infusion. And he went home to America. He lived a couple of tail. So, and we can get that big dose, because if I remember right, 6 milligrams of Dex is equivalent to 150 of hydrocortisone, if I remember my corrections. And so he had 16, so probably about 500 equivalent. A big dose, and just anecdote that I'm be impressed with in these, but some wouldn't advocate every patient should big doses of steroids, but in sort of when they completely lost their vascular reactivity, I'd anecdotally term it very useful. And literally, see within a minute, he was pinking up. He was actually, you could see a little bit more colour in his limbs, and the hemodynamics, there was quite a marked improvement, literally within a few minutes. So we got up to 6.7. And then we did lots of different things at a time, if you get protein C and antithrombin, lots of different things. And that was him 10 days later. Why do I mention women? Because essentially we had lots of, when they told this guy coming with meningococcal things, lots of young single women with babies coming in saying, well, I did it. What's my baby? And, so that just moved them to the sort of public health people. You need to sort them out. And so we shifted back to Manchester. We're going to be safe, or the women of London would be safer. And it made a full recovery, just lost, apart from losing 2 toes. And he was that shut down. But 2 toes is, there is a fairly reasonable trade-off for surviving. Okay, another one. This is a young man who's 31. He had leukemia, got his chemo, became neutropenic from the cytopenia. And on the ward, 3 days later, he collapsed, hypotensive, he vomited, aspirated, he was very hypoxemic. He was tuned on in the hematology ward, given a lot of fluid, and he was moved to the ICU. And on arrival, he had a pyrexia, very tachycardic, 160, hypotensive. He had a Hickman line, and the pressure through that was, if it's reliable or not, but it was reading 11 on 100% oxygen. He was barely oxygenating. Lactate was 5. Obviously, he was, the hemonc patient, so no platelets, no white cells, and a low hemoglobin. He had a whiteout, show you an X-ray in a second, a whiteout on his left side. And these things, it was difficult to read. It was going very fast, and there was a lot of umming and ahhing. Was this non-SVT? And the cardiology reg, I think, was around the time, and he was, again, there was lots of muttering. That was his X-ray. Not very nice, is it? Okay. So I think I'll show you the figures. What's it, Daisy? Okay. I can show you the figures back again, but it gives you the options of cardioversion,
try an antiarrhythmic, a vasopressor, fluid, or something else.
Oh, sorry, yeah, I forget the answer. Sorry, went the wrong way. But, yeah, sorry. Without knowing the answer, what would you have done? Cardiovert? Yep. Any other cardioverters in the room? Fluid. And how much fluid? He'd already had 3 litres. It could be needing more. Yeah, fluid with monitoring. Sorry. Yeah, blood. Yeah, so obviously gets the blood up the absolutely. I mean, it's reasonable to, think about giving in some blood.
Glass the pièces.
Pardon?
But there's those songs.
Yeah, I mean, best sort of. And so, lots
Stomatics.
obviously those things taken as read, just focusing on the circulation.
The Doppler, I can sorry, don't have a picture, but it was off the screen. Yeah. He was young, fit, and literally over 20 litres. He was literally off the screen. It was that good.
So does he need fluid?
No. Yeah, I agree he needs blood eventually, but, you want to top him up, but not in the first instance.
And he needed a lot of NORAD. Eventually got Klebsiella in the blood. And I grumped him and got loads of gubbins out and basically the void felt good. We had a bug. Yeah, the lung was improved. We could, eventually get tube out and he went home. And that was him after an extubation, other than a bronchoscopy rather. And there's the Doppler probe in the middle. And this is Hickman line going up there. Yeah. So again, it's just having that information. Yeah, because he was actually quite shut down peripherally. So I was surprised that it was 20 litres per minute, but it was all central. Rather than, he was all shut down there, but he had a very high central circulation. Okay, I think this is the last one I'll give you. It is a man of God. The golden Doppler on his side. And he came in now then for a AAA repair, aortic aneurysm, and came to the ICU afterwards. He didn't have any history of no cardiac problem, an ejection fraction of whatever that means of 50%. And the surgery was allegedly unremarkable. There wasn't a huge amount of blood loss. He did drop his blood pressure at one point in the operation. They quickly responded to fluid, and at the end of the op, he was 2 litres positive. Okay. And when he got to the ICU, they were the number. So he was tachycardic. Blood pressure was 150 and 100. The CKP was 8. Was peeing well. There's nothing on the chart of him having had furosemide. That he was peeing well, and he was acidotic. Okay. What would you do?
He was still intubated, which is bad.
Assume you just didn't have one. What did you hear us pain medicine? So good point. So could it be pain? Yeah. Could it be fluid being asked? So you did get both. So you had coed and antigonopia. Yep. And an hour later, he was still tachycardic, a little bit better. Blood pressure was, if anything, a bit higher. CV did gone up from 8 to 13. He was still peeing well. It was more acidotic.
Should lose it already, Dave.
So, a vasodilator? Any other offers?
So you're still tachycardic. So who would go for a vasodilator?
Inotrope? Anyone for inotrope? Fluid?
No, we go for two. One hand for fluid. Theta blocker. Okay, he needs to pitch it in the cage pocket. I think he will need it to be. Oh, something beta blockade. So there was an argument for beta blockade. Any other ideas, thoughts? Okay. Doppler, clearly, that's the answer. And that is a picture. So it was about 2.6 litres. Again, a very narrow corrected flow time, 159. Who said fluid? And so brownie points. It suggested he was underfilled. So he had 200 mils. It got better, and then it got worse again. What would you do now?
There was a transient improvement when he got fluid, and then it was bleeding.
Could he be bleeding? Yeah. But more fluid when you go? Sorry.
Yeah, sure.
Yeah. So after an hour, repeated challenges, he had 2 litres. And the output was a bit better. The corrective flow time was better, still subnormal. The heart rate was a bit down. The blood pressure was still lower, but good. CVP, despite the fluid, lower. He was still peeing well, more acidotic. Obviously giving him fluid ROS because of blood, but he was obviously diluting down with his hemoglobin. So what would you do now? Call the surgeon? No. It's a window monitoring with the lads up in perfect operation, I think you want.
Heard that one before. Yeah. And so they couldn't be persuaded. Anyway, we continued. And by another 2 hours later, you had your total 5.2 litres in blood. And the Doppler looked a lot better. The cardiac output, peak velocity coming up again still. And now just about in the normal range. Less tachycardic. Blood pressure still okay, but lower. The strike 5 litres, receiving he was only 12. Peeing well. Unaided, not given any diuretic or anything. Acidosis a bit better. And the hematology, obviously, was getting some blood. So we can call the surgeons back. And then, just to show you the Doppler, you can see how it got better and then it was getting worse and then it got more fluid. So you can see that it was a dynamic, sort of evolving situation. And we were obviously trying to keep up and on top of the presumed fluid loss. And his abdomen was obviously really distended and big. And actually, I really had to twist an arm to actually get him to agree to take him back. And that did. And they found a hole in the commoniac, and there was 5 litres of blood swishing around his abdomen. And they repaired the hole, and he made uneventful recoveries, which is good news. The morals of the story, I think the pig would have dropped eventually when he had no blood pressure and he was really ill. That, what is going on? Is there something going on inside? And I think just getting ahead of the game hopefully made a difference, allowing him to make an uneventful recovery. And also, very importantly, you never trust the surgeon. Nobody's disagreeing. Okay. Actually, I'll give you one more. Got the energy for one more? I think. This was, actually, it was a Pegmas journalist. So they were at another hospital considering him, this is years ago, for a lung transplant. Because he had very severe lung fibrosis, which hadn't responded to any medical therapy. And he came into UCH with dyspnea on a Saturday morning. And on 40% oxygen, he had low VaO2 and he acted near. They listened to them. Not very nice, is it? Horrible lungs. And he improved on non-invasive ventilation. But 3 days later, he just acutely deteriorated and needed to be intubated. And post-intubation, he had a blood pressure of 68, systolic, tachycardic, and a CVP of 13. What would you do? Echo, yeah, I can. But this is a few years ago. But I mean, I think an echo absolutely. But I agree with you. But we didn't have at the time the capability. Nitric oxide. Nitric oxide is an option. Yep. Improved gas exchange. You hope through perfused areas, ventilated areas, and would improve the perfusion. Yeah, this is a reasonable thought. Anything else? What about hemodynamics? Heat hypotensive and CVP of 30. Noradrenaline. Yeah, reasonable. Get blood pressure up. Okay. Fluid. Adrenaline, to a 9 after maybe a 9. Yeah. And it's a good chance that he's got cor pulmonale, with his horrible lungs, and he's got a degree of right heart failure. Okay.
The resident tried some sort of challenges, no response. Someone was actually literally arrived there. He'd been to Meth on a low dose of the butamine. I put a Doppler in, and there he had an 18 mil strength volume, tachycardic, looked empty, corrected flow by 150. Boom. So I thought, look, try gentling, do a challenge. And it got better. Not huge, but it did get better. So it got better with the challenge, so let's repeat the challenge, repeat. Then nobody was going for fluid, so that's what you got. And you can see here over 2 hours, by the end of 2 hours, he had 3 litres in total. The heart rate came down, the blood pressure came up, CVP came down, the cardiac output came up, the throat volume came up. So again, he had right heart failure, but he actually benefited from the fluids because we were challenging, then. And obviously we improved the ventricular function. I thought he would be useful to have a PA catheter, and it took me, and you'll see the reason why, ages. You have to put the damn thing in. Well, you'll see why, because I did a left neck approach, because he had the central line on the right. And the PA pressures at the time showed, he had very high PA pressures. And actually, the cardiac output was married up quite well. And the reason, there's a Doppler probe, I don't know if you can see it, but the left-sided approach, and then you see it does a right angle turn, then another right angle turn, and then it comes up into the pulmonary artery. He had a left superior vena cava, which made it a bit difficult to get round the bend and round the bend, but up again, anatomical quirk. Yeah, some people are bored with tim vena cava, superior vena cava, dorming from the right, but anyway, anatomical quirk. So I think the CVP, again, when you have a poorly compliant ventricle, often it's useful, but sometimes, the high CVP, when they are constricted, when there's poorly compliant ventricle, it can, over time, they don't need fluid. They dive.
But you're able to guide it when you've done up.
Exactly.
What makes the difference?
Yeah, because and you're doing little and often. Yeah. So have you not responded to the fluid? Like I showed you with the meningococcal sepsis, this guy, 200 mil got worse rather than better. No more fluid. So it gives you a little bit of reassurance that, supporting your clinical judgment. And, you got better.
Pleasure.
Thank you very much. Thank you.